Hi, thanks. Sorry. Sorry, it took me a little bit to figure it out. It's early here. I'm having a bit of a hard time hearing.
You're mute today.
Yes, sorry, what you're saying, I would just grab the carriages and get them to that. You know, if I could like grab the screen and just drag it into a new session, that would be ideal. I'm not doing anything.
Jamie, sorry to interrupt you. You are on mute. There we go.
Apologies, it's a tad early here. Thank you so much for joining today. I'm happy to take questions on behalf of our entire team now. I don't know exactly how the tech works. I think I can see questions in the chat, so please feel free to send any questions, comments. Really appreciate feedback on our research as well, and ideas for future studies too. Thank you. Also, I do see a question that I tried to address in the chat from Dr. Juliet around, her question is, in measuring the impact of videos on the community understanding of COVID vaccine, how did you remove or estimate the impact by other existing or ongoing COVID vaccine promotion messages, social media, by existing structures, including government efforts? So there were a lot of activities that were happening in Guatemala that were meant to be promoting vaccine acceptance. And these are things that WUKU were trying to coordinate alongside the Ministry of Health and the Guatemalan CDC. We specifically weren't able to kind of remove that impact and understand the difference between the impact of those efforts versus our own. However, in our research design, we really tried to understand specifically, were our videos being viewed? What was the engagement? And was there any kind of impact in attitudinal changes of those who were viewing the videos or exposed to the videos? And that is where we really tried to do the specific pre-post in the target communities where WUKU works most closely to follow up specifically with the same individuals. And one of the ways we tried to understand whether or not they had viewed our videos was in the post surveying, we actually showed them images of the videos themselves to see if they recognize them. And then we asked about their vaccine status. With the BrandLift tool through the larger social media campaign rollout, what we did was had a control group that had no exposure to the videos. So we were able to roll out the videos and promote the videos in a way such that we knew that the individuals in the control group had no exposure during that 3-week window to the videos themselves, so that then when we conducted the polling, any differences would ostensibly be from viewing of the videos. I hope that answers your question, Dr. Juliet. I see a quick follow-up that did you possibly have control communities where none of your interventions were done? So the way that the polling works for Facebook is that we did know that it was a subset of, so control communities are those. Oh, sorry. I think maybe your question is asking around, could we have had a controlled Indigenous community where we did more of a difference in difference and did that analysis? And that's a wonderful idea. And it's actually something that we are attempting to do at the moment. So we are working with the government to get access to vaccination health records in order to do more of a controlled comparison using a difference in differences approach. We are currently doing an interrupted time series, at least on the target communities, to look at the pre and the post, and we're trying to get access to more of those trends data to understand whether or not there's more of a causal impact on vaccine uptake in the target communities. And I hope that answers more of your question. Happy to continue following up, or please feel free to reach out to us directly if you'd like to have a longer discussion about this. Thank you so much. Those are really great questions. I see another question coming in, or a comment. I can read it out. Our keynote and leadership address also reflected on the resistance that sometimes accompanies these activities. How were you able to encourage uptake within the communities to this initiative? So I think one of the great things about WUKU is that they are very much embedded within the community and working locally with health workers, directly with clinics. And our group at the Stanford Center for Health Education always kind of follows an approach where we work closely with local organizations. And so, we have access to a lot of faculty and medical expertise at Stanford and elsewhere in the world, but what we don't have is that that empathy for what is happening in local communities. And I think the COVID-19 pandemic really brought out that is so key to trying to reach people, to approach them in a way that that allows them to actually accept the messages that are coming through. And I think what we have learned is that these prescriptive messages from national governments, from the WHO, these and ivory tower academic institutions are not necessarily going to reach people and to help them to feel good about the health information they're receiving. In Guatemala, I think this is one of a case study in this really being complicated by past historical events and just the mistrust that's happened even around receiving messages in Spanish, the colonial language. And so Wuku Kowak really dedicates their work to reaching indigenous populations that have to contend with a lot of this history to be able to reach these groups to help them get the key health information they need. And so we really did this and did a very in-depth formative process to understand what people were thinking to begin with. And so that is where we did the series of focus groups and interviews to talk to health workers, to community members. What is going on? Why don't you trust this information? Why are you hesitant about vaccines? So that we could create health education content that specifically addressed that. And I think approaching it not from the lens of course you need to understand this and why wouldn't you get the vaccine? It's really, let us meet you where you're at. Let us explain why these concerns are things that are valid, but we have evidence to be able to suggest that this is something that it shouldn't be concerning them for getting the vaccine. And so that was really the approach that we took in this study, as well as in other work that we're doing globally. Thank you so much for that question. Thank you. So I'm going to read out the comment again. As a follow-up, and perhaps it is early to determine, but are you able to observe behavioral change within these communities to which these initiatives are directed for the positive or otherwise? Was video a good way to get the message across? I think that's a really great question, because I feel like many times these studies start with a pre and a very short run post, and we say, oh, they had the intent to get the vaccine, and or they said that they got the vaccine. So in the communities, we did see that initial uptake of more people who had said that they had seen the videos actually being vaccinated at the time of the post. Currently, we don't have plans to follow up with the same individual people, but at the same time, that is something that is quite possible that we can do. And I think what we are actually doing now and pivoting to thinking about future work is to actually do something similar, but addressing more generally immunization. And so unfortunately, I think, globally, one of the side effects of this pandemic is that there's been a huge drop off in terms of childhood routine immunizations. And so what we want to understand in future work with these communities and elsewhere in Guatemala is what happened with routine immunizations. How are people feeling about these already? I would say that, the uptake wasn't super high, but I think that what we're hearing anecdotally from our colleagues in Guatemala is that people are hesitant. And now because of the pandemic, everything is more confounding. And so we want to address that. We want to understand more about the behavior change. We want to understand whether or not we can use videos. I think we've got a lot of positive feedback that the videos were great. One of the things that I didn't delve into in terms of our Facebook analytics is that we had much more engagement among the younger subset. So certainly between 25 to 34 was our biggest subset of viewers of the videos themselves and engagement. That's not surprising to us in any way. The community level surveys were interesting because what we observed, at least, is that older respondents were actually shown the videos by their younger family members and acquaintances. And so we do think the videos, even through social media, may be reaching people further than what we can actually measure through analytics.
Thank you so much, Dr. Johnson. I thought I'd come on and take advantage of your presentation and questions.
Perfect.
And the reason is in South Africa, we have 12 national languages, actually, and that they are national. So they're acknowledged within the curriculum and in terms of translation of policy documents into those languages. And so my follow-up question would be, for these languages that you picked, are they considered primary languages? Are they taught in school? Are they languages that are spoken in the home?
Thank you. That's such a great question. And so what we did was we chose the top 2 most prevalent spoken Mayan languages, indigenous languages, after Spanish. We knew that this was really a set of communities that wasn't getting the health information they need. And there's constantly feedback that we don't get this in our language. These aren't the languages that are taught in schools. However, they are spoken in the homes very prevalently. Most of the younger Quiche Maya language speakers also speak Spanish, at least. But we think that there's an element around language that isn't even around comprehension. And so one of the reasons why we wanted to look at the BrandLift to compare Spanish video compared to Quiche video for Quiche speakers is that everyone on social media is going to have some at least nominal understanding and ability to speak Spanish, understand Spanish. And so they, ostensibly, if you're putting up a Spanish video and a Quiche video side by side, that information should be conveying, should be getting to that user regardless. But is there something different about hearing health information in your own native tongue, in the language that you speak at home with your friends, with your family? And so that's where we really wanted to understand, how important is it to take the time and the effort to translate health information into languages that aren't spoken as widely as some of these colonial languages? And, the BrandLift did show that there is evidence that the safety perceptions around the safety of the vaccine were impacted by seeing the Quiche video among the Quiche speakers. I think it's really, it's great. South Africa is an example. Actually, half of our Stanford team is in Cape Town. We have an office there, and over half of our team is based in Cape Town. And so we're also trying to work and creating videos and health education to address the major languages that are spoken in South Africa. We have quite a bit of content in COSA. We work more closely with organizations in the Western Cape. But I think it's an ongoing question for us because there is cost and time associated with translation of health information into languages that are less widely spoken. But we really believe upon the work that we've done, this study specifically and others, that making that information available is really an important thing to do and essential. I think people all deserve the right to health information that they can understand and trust and be able to engage with in a way that they feel comfortable. So thank you so much for that question. We'd love to chat more about your work as well.
Thank you. Yes, Dr. Johnston. And I'll add just one more dimension where I have seen that demonstrated, the importance of language. In your question, how important is it? So I come from a conflict resolution, peace building background, and having worked in the conflicts in Bosnia and Herzegovina, and then moving into the transformation, peace and reconciliation exercise that South Africa pioneered, language was instrumental in the capturing of the narrative and the truths of the experiences experienced by the victim and the perpetrator. And so in Bosnia, as we saw here in South Africa, language, the stories were translated, and in the resources were invested to enable translation so that reconciliation and understanding of the root of that conflict could be communicated in that person's ideology, but also to reach the identity of that conflict mitigation factor. So it was critical. I wonder why the question then hasn't been realized in the health space. And that's my question to you.
That's such a great question because it's something that our center struggles with constantly around how do you first of all get that local knowledge? I think there is a lack of access among these higher, I don't know if that's not the right word, but these institutions at the international organization level, even at the national level, the local access to groups that are disenfranchised and marginalized, and the ability to pull that expertise in. For one, there has to be a willingness to do it. And I would say that our center has that willingness, but then there are barriers around being able to do that, and also being able to have that language ability to, approach these communities, work with them in a way that has them understand, what is going on. There's such a history of exploitation around the world for, centuries, right? We all know that. And so the question really is, how do we access that local knowledge to be able to reach people where they are at? And one of the things that, over the years of our centers, our center is about 5 years, actually older than that at this point, we really started first at this level of, okay, let's do medical education. But what we realized is that this information at medical schools, at the ministry level, wasn't reaching communities. And we really see that is happening much more so with community health workers globally. These are the frontline health workers that are from communities, in communities, reaching communities. And so we have really pivoted to targeting our health information, our health training, and working closely with community health workers. We do that through membership in the Community Health Impact Coalition, which is a coalition of members globally that supports community health workers, employs them, and really promotes the idea that this is a professionalized workforce. We need to treat them as such, and we need to get them the information they need, because they are the ones who have the local knowledge, the local language capacity to reach communities. And so we really see community health workers as one angle where we can try to reach these communities. This study specifically doesn't work specifically with community health workers. However, WuKuKuWalk is part of the Community Health Impact Coalition, CHIC as they're known, and they do work closely with community health workers. So in addition to training community health workers, we want to produce tools, educational tools that will allow them to reach their communities. One way, and a lot of feedback we found, is video's great. And can we have, videos that are low bandwidth, able to be shared through platforms that they're already using? So many community health workers are on WhatsApp. We actually have an advisory group that we communicate with, very low tech, just WhatsApp. We have our team member in South Africa who, she's a COSA speaker. She's texting constantly with community health workers. And I'm definitely rambling at this point. Please step in with additional follow-up.
Thank you, Jamie. I think you hit the nail on the head there. And then I guess my follow-up question would be, how do you overcome stigma? So you're coming with new, regardless of what you're translating into your mode of communication, video, right? But we saw that those channels can also be the very source of sandpaper moments, right? Like rough around the edges, So you're still having to build relation even as you're meeting it. And in medical education, international education, we're finding a very strong focus on the need to develop intercultural competencies, right? So that skill to be able to translate into that other ideological way of viewing life, again. So we call it indigenous, but there are patterns of life that are also responsive, for example, to the COVID pandemic. And does your mode of translation accommodate for those knowledge systems?
Yeah, I mean, it's really so hard to identify even these sources of stigma and things that we would have no idea whether or not they are going to come up when we're trying to even say, take a video. And I will say that the videos in this study specifically, just a smaller subset, started from videos that were developed by our team for an audience in New Zealand, totally different from indigenous communities in Guatemala. And so applying that lens of, okay, we're going to take a human-centered design approach. We're starting at a starting point with basic science information. Just a minute, sweetie. Sorry, I have my kids. And so, sorry. So we start with this basic health information, and then we bring it to the communities, and we prototype the videos to say, what about this don't you like? What do you like? What doesn't make sense? And so we do try to apply that lens whenever we are, translating, but also adapting our content for cultural and contextual issues. So I think that that's key, but also I think it's key in working with those who would be delivering the health information. And that's where we go back to the community health workers, working with the trainees of community health workers, assembling groups of community health workers to advise us on our content creation, which is something that we have been doing now for a number of series of community health worker focused education. And so we acknowledge that, and we don't think that we're great necessarily in addressing it always, but we do think that we are trying to bring that into the dialogue of health education creation.
Thank you so much, Jamie. And again, very topical. I just want to invite you to consider the study shared in the chat by Dr. Yarmoshuk, a Wellcome Trust funded study. I think there's a link there looking at language-based equity in the African region. I think just some resources additional to your team. And then I'm very interested, I'm just going to keep going here, but the idea then is within a South African context, in South Africa, in Stellenbosch University, impact is one of our focus areas. So a really underpinning dimension is what impact is your research seeking to attain now, medium, short, medium, and long term. And then looking as well at, that is, like you said, human-centered design, but inviting the rural dimension. So we are peri-urban communities with an urban and rural communities. And so we have a rural school, Worcester Medical Campus, where we have rural education based on medical training. And so to what extent were your translation, your videos able to incorporate that medical model in your Indigenous communities?
That's a really wonderful question because, I've been talking a lot about community health workers and going into communities specifically to get that information, but we should be drawing more on the medical expertise of, the academics, the scientists in these communities that understand. And I do think that is one thing that our center is trying to work on, more global collaboration with academics elsewhere. So not just sitting here in California, we partnered with UCSF, they're our neighbors just to the north. And I think there's an importance to work with the local, CHW, community health worker, community-based organizations, but we are very much interested in working more with academics in other institutions, medical schools. And so honestly, attending conferences like these, hearing about the expertise from other experts, other academics elsewhere is really key to us as well. And I think just trying to foster these collaborations, definitely invite you and others, would love to reach out to have more conversations. How can we work together? How can we create education in a way that that does this? I don't think that, we're very committed to the work that we do, but we don't have that local expertise, as you know. And I think that that's where we need to foster this sense of collaboration across institutions around the world too. And thank you so much, Dr. Yarmoshuk. I want to check out this study and to circulate it with my colleagues as well.
Well, Jamie, we have 10 minutes just about, but I think the last one is to just echo your sentiments on the importance of that cross-regional interdisciplinary collaboration, exploring that sharing of new knowledge at what we call the periphery, I think, because it's not known. We haven't brought it to the surface. But I'm excited to see that you already have a team here in South Africa doing that good work, reaching out to yourselves in California. So building that data, that knowledge base from which you can then improve your videos and other communication channels. Very important work. I just want to thank you again for your panel. I know you're here, but to your colleagues who gave their inputs on the videos. Stellenbosch is one of those interesting institutions that seeks those collaborations, and our Department of Global Health is but one of those spaces in the Faculty of Medicine and Health Sciences. And we have in this conference actually every participant from every region in the world. So definitely the topic then is relevant, not in North America, not only in the Africa region, but across the planet. So there is something there to build on and to generate some level of momentum. So even if it seems slow going, I think then it is a very useful and important trajectory that you are cultivating with your research. So thank you so much. I would invite you to continue sharing that with us at our international forums, with our faculty, with our students, our researchers as well. Do you have any other insights you'd like to share with us? We do have those on the line as well.
Well, first, just thank you so much for those kind words, and just Dr. Maguire, we'd absolutely love to continue the conversation, and honestly, invite that kind of dialogue with other attendees. Please reach out to us. I think that we would love to talk about ways that we can collaborate. Also ways that we can just support the work that you're already doing, because I think that there's so much excellent work that's being done. And, in some cases, we can play more of a supporting role in the way that we create content. And that's how a lot of the work that we have done has come to be, where we have, video production skills, and we are able to do that with our team, but we're also able to just support initiatives that are already underway in a number of places. So we really invite that collaboration, and thank you so much for this opportunity to share here. We'll continue engaging, and this is just such a great conference to be able to do that and to engage with, others who are like-minded as us. Thank you so much.
Absolutely, Dr. Johnston. Thank you for bringing that artistic flair as well. That's the only word you didn't use is art. The use of media, the use of artists.
We have a very talented team of artists who are really amazing, and how quickly they can illustrate. It's always shocking me.
Absolutely, and we shouldn't forget the talent that group of people bring to idealize and to bring to life these ideas actually through illustration. So the next generation responds to visual, they respond to short messaging, and they respond to this type of keying in to these very topical messages. So thank you for bringing that key message into the new generation as well. Hopefully they're receiving the message and acting on it. Yes.
Thank you so much. Thank you for this opportunity to share.
It's a pleasure. So once again, to anybody in the room who would like to share a question or comment, or thank you to Dr. Johnston before we close the session for the day, you are welcome to use the Q&A or the chat. I welcome you to please fill this session evaluation. The post was placed in the chat, and you can access it through the link.
Thank you all.
Thank you too, Jamie. So Jamie, I'll give a few minutes just to know we have recorded the session. As soon as it is available, which is pretty much immediately, we will repost it back into the session so you and your colleagues can revisit it at your leisure.
Thank you so much.
Excellent. Once again, colleagues, thank you very much. Dr. Juliet Nyasulu for your insights, Dr. Aaron Yamashuk for the links, to Jamie Johnston and her colleagues for the contribution to this conference. Once again, we thank you and express appreciation for the inputs and topics you've shared with us today. We have one last segment to close our session for day one. In the plenary, we just have a musical segment. A thank you to our sponsors as ever for bringing us to this launch of the CUGH African Global Conference for 2022. So I will clock off, I'll put my video, and we will move to the stage. Jamie, thank you, and good day.
Thank you all. Have a great day.
Bye.